Happy Friday, everyone. It's Doris Branker. I hope wherever you are in this part of the world or country that you find yourself safe. I wanted to do this video with regard to telemedicine and telehealth. This is a hot topic right now that is trending, I think, everywhere on social media. And literally, I've been following this for about 2.5 or 3 weeks, and there's almost daily updates to what we're seeing. So I'd like to hit a few points. I'll try not to make this video very long. I'll talk about the 1135 waiver that we're seeing. I've gotten a question on what is that? Like, is that important? Do I need to know what that is? What is telehealth exactly? What is not telehealth? Some recommended documentation requirements, what you should be doing now if you haven't already, as well as some payer instruction. I want to preface this video by saying telehealth in its current state is a daily changing thing. Even before the coronavirus emergency, telehealth was something that like any area of coding, I don't find it to be different, but like any area of coding changes. Right. So what the government says and what they do and how it's reported could vary when you look at the state level. And when you look at the government program at the state level, for example, Mother Medicare says one thing, the local Medicare administrative contractor facilitates that in different ways in different states. Medicaid does it some other way, and then the commercial carriers throw a curveball that's totally different from that. So I'll preface this video to say nothing in this, and I think really I'm not looking at everyone else's videos online or anything, but I don't think anything in any video is going to negate or override your responsibility as a practice to do your diligence, right? So let me jump ahead to what I was going to cover. What you should be doing now in your practices is looking at your payer mix. If you don't have that set up, this is where this is going to be very difficult for you if as a practice manager you have not done that kind of diligence first. It is very important that you know as a practice where your money's coming from. That is your payer mix. So who makes up your reimbursement? What percentage of your patient volume is, Medicare, Medicaid, Medicare replacement plans, Medicaid replacement plans, commercial, and not just commercial. That should be further demarcated to say United, Aetna, Cigna, AvMed, whatever your payer mix is. There are some plans that are at a local level and only in that particular state. Right. So if you haven't done that diligence already, you definitely want to do that because that's going to help you understand how you navigate through this. Demographic information, if you are not a practice who is good at keeping that information current, you may find yourself kind of tripping up lately just because when you look at some of the code requirements, we'll talk about patient initiation and being in contact with your patients and connecting with your patients. If you don't have valid demographic data for your patients, that is a way to contact your patients, valid phone numbers, email addresses if they exist, for example. I have no idea how you're going to connect with your patients, period, let alone in a state of emergency. So if you're not doing that now, if you haven't done that yet, I recommend you do that now. A way to support your elderly patients. If you are currently in the office, your office has not shut down yet in the state of an emergency, I recommend you have a designated person or people in your practice to assist your elderly patients. One of my practices told me, yeah, that sounds really great with the telemedicine stuff, but our patients aren't interested, and it's strange because they don't have a very high volume of elderly patients, but they said our patients really aren't, they feel like it's too complex, they can't deal with it, and I know that's something that we hear a lot in the elderly because this technology thing, this is something they didn't really have to deal with before, it's complex, it's confusing. They don't want to deal with it. So having a person in your office, if your office is still open, to connect the patients to the portal via their mobile devices. A lot of our elderly patients have mobile phones at a minimum, so connecting them via mobile phone to the portal and showing them how to interface is going to be helpful. That's something you can do now if your practices are still open, so you can treat those patients in the event that you are quarantined and you want to have a continuum of care. So let's talk about the 1135 waiver. What is that? Simply put, the 1135 waiver kind of ties back to the Social Security Act. It's a part of the act that allows, in times of natural disaster or states of emergency like our current state, it allows the government to provide flexibility in federal healthcare insurance programs like Medicare, Medicaid, and the Child Health Insurance Program. It allows them to provide flexibility. This is why telemedicine, for example, had very rigid regulations and definitions, such as originating sites. It has relaxed the definition of originating sites. It also requires responsibility on the part of insurers and providers. For example, if you are a provider who normally, and I would not admit to this if I were you, but normally waives the patient's cost share, their deductibles and their co-payments, you may not be aware that you are actually breaking the law. You're not able to do that legally. Under the 1135 waiver that's been granted under the Trump administration, you are now able, for telehealth services in the time of disaster, decide whether or not you want to waive that patient cost share without the penalty of worrying about the arm of the government coming down and cutting off your head, right? So those kind of things are afforded to providers. Sanctions on things like that are waived. Outside of just out and out fraud and abuse, you have a lot of protection under the 1135 waiver. Because, and this, whether you see a lot of Medicare or Medicaid or not, understand that if your patient has Medicare or Medicaid, that also trickles down to the Medicare and Medicaid replacement products. Okay, so that's where it's important, because some practices like, oh, we don't see a lot of Medicare. We don't have a lot of Medicare. No, you may not have a lot of claims that are being paid by traditional Medicare, but if a patient has a Medicare replacement or Medicare Advantage program, Medicare Part C, they follow the rules of Medicare in many regards with regard to program administration on what they must cover. So the 1135 waiver gives some leeway with regard to that. So this is what we've seen lately, a lot of like almost daily updates with regard to it. They've relaxed the originating site regulation, requiring typically the originating site is the site where the patient is. These patients would report to a designated type of site or facility and be connected with a provider at a totally different location. That is what telemedicine is. That was the intention of telemedicine by its definition. So understand, some of this medicine that I'll call technomedicine is being misclassified and characterized as telemedicine. Telemedicine, and the intention of it, was that situation where a patient was at one specifically designated type of site and connected with a provider at a different type of site, a different site. If you weren't in one of those designated type of sites, it wasn't telemedicine. Now, as I preface this video, CMS tends to update things, and see, commercial payers and other payers are I've learned that they're very, they duplicate, right? They like to duplicate what Medicare does or CMS does. So after Medicare or CMS kind of pays the money and does the research and writes it out beautifully, they kind of copy exactly what CMS does, but they don't always do that as timely as Medicare does. So what happens, and this is why you have such varying rules and instructions, because they don't update their policies as frequently as Medicare. So when Medicare stops doing one thing, they may not stop doing something else. The reason you see so much variation when it comes to telemedicine, for example, you'll have some policies that say, you use the GT modifier, and some that won't, because, for physician claims, a lot of them don't use the GT modifier anymore. It's not used. In the same year, they were using the GT modifier, and CMS put out a rule saying don't use the GT modifier for physician claims in the exact same calendar year. But maybe a commercial payer only updates their policy once a year. So that'll kind of carry over. Others will tell you just use the place of service to. Another payer will say don't use the place of service to, use the modifier 95, because the modifier 95 tells us and affirms that you've used telemedicine, right? That you've met the requirements for telemedicine. So I want to talk about what telehealth is. So hopefully you understand what telehealth is. What codes would you use? first, the basic requirement that has stayed consistent, even in midst of the coronavirus emergency, is the requirement for real-time audiovisual communication. The Office of Civil Rights, which is the entity responsible for HIPAA enforcement, actually released, was it yesterday, 2 days ago? Today is March 20th. I think yesterday or 2 days ago, they released notifications stating that they would not penalize providers for using types of technology such as Skype, Messenger, FaceTime. I think that's an iPhone thing. I don't have an iPhone, so I think that's an iPhone thing. And to satisfy the real-time requirement. So if you have an electronic medical record system, EMR, EHR, that is not capable of that real-time audio-visual communication, which FYI, you should save an image of by swiping, or if it's in your EMR, there's a way for you to save an image. If you're using Skype or something else, I would swipe to save that image and store in your record as evidence. If you're using that, it has that capability. If you're not, swipe and store. You cannot bill telehealth, the true telehealth codes, unless your system has that capability. That has not been relaxed. What they've relaxed is specifically what you can use. So typically FaceTime and Skype and Messenger were not acceptable technology resources that you could use to satisfy the requirement. Now they are. So that's unchanged. The codes, I asked, well, what codes do you use for telemedicine? Before and outside of a corona emergency, the codes we were able to use for telemedicine were the same codes that we used if the patient came into the office, right? So if you saw that patient and you used a consultation, it was a consultation. And again, CMS doesn't pay for consultations anymore, but you may find that some of the Medicare Advantage plans or replacement plans or the Medicaid plans even, it's funny, Medi-Cal still pays for consultations and they don't pay for a lot of other stuff, but they pay for those. So if they pay for consultations in the office and it's telehealth, you could still just bill the regular consultation codes through telehealth. So there's no difference in your codes. And because there's no difference in your codes, there's also no difference in your payment. So there is no payment reduction when you're using the real telehealth codes, right? So in traditional non-coronavirus type situations, however, under the coronavirus emergency, that means that I could use a 99201 under normal circumstances for telehealth. Part of the 1135 waiver that relaxed and made the patient's home an originating site, because remember, we're doing the social distancing thing now, where we want to avoid spread of the virus by kind of sequestering ourselves and staying away from people. They've made the patient home an originating site. Because they've added that as part of the 1135 waiver, they've also added a requirement that the patient must have an established relationship with the provider. So although normal telemedicine scenarios would allow you to bill new patients, under the 1135, where you're treating these patients from their homes, you are not able to bill 99201 to 99205 or any of the codes in which you do not have an established relationship. So does that mean if you're in a program where there's a consultation, for example, you can do a consultation? Sure, you can do a consultation if you have an established relationship with that patient. If you do not have an established relationship with that patient, then you would not be able to bill a consultation, even though the code set doesn't change based on new or established. That is what they're kind of requiring in the rule. So that is how you would actually code it. What gets to be a challenge and what you'll have to research with your payer mix at your state level with all these different rules is whether or not you'll need to use the place of service 2, which affirms that you've met the telehealth requirement of having that audio-visual real-time communication, or the modifier 95, or a combination of both. If your payer policy is really outdated, I don't even know if you won't see a GT. GT has been kind of abandoned for the physician claims for a lot of the Medicare administrative contractors when Mother Medicare kind of abandoned it. But what you're going to see in a payer policy at a commercial level, I can't tell you because this is where your payer mix and that level will be different. There's a lot of arguments kind of on the different social media sites. Oh, no, that's wrong. And no, you should. You both may be right. It just, you might be right for your state and that person may be right for their individual state. So unfortunately, this video won't really dispel that for you. You are still going to have to do the research at the state level on how to properly bill telemedicine with regard to your place of service and or the modifiers. But place of service 2 is what you can look for telemedicine. Again, that says I'm using a proper system. And now with the waiver, that would be applicable for Skype and Messenger or whatever, or modifier 95. Okay, if they don't want place of service 2, you can use the place of service 11 and do modifier 95. So again, you're going to have to research that to find out what it is for you. A special consideration with regard to those telehealth services is, and again, I'm not a big social media person, so don't hold me to this, but you may have to connect with your patients. I would maybe get another phone. Like I don't know if the patient has to have your phone number in order to connect with FaceTime, or you have to have your social media profile to connect with you on Messenger or Skype. I don't know how that works, so that seems like a whole other thing to navigate. It may be a good idea to have, if you have a practice page, for example, already on some of those social media sites, it could be a good thing for you because you could just connect that way. No matter what, I would save an image. I know definitely for Messenger, it has a way for you to take a picture of what you see. So when you are connected with your patient, you both are on the screen, take a picture of that, save that picture and store that in your medical record for documentation purposes, so you can prove, if necessary, that you weren't fraudulently billing when you didn't have the capability to connect with the patient via real time. So that's definitely from a documentation requirement. I need to be able to, when a person looks at your documentation, it should be evident what you're doing, and it should be clear in what you're doing when it's memorialized. So let's talk about what is not telehealth. I like to call this techno-health, not telehealth, but techno-health. And I think the tricky part of telehealth, with it being tele, that people think telephone, that's not what this is. Telephones are technology as well. That's why I call this techno-health. Telehealth is what I described before. Patients at one site, the provider connects to the patient at a distant site using real-time, both audio and visual, right? So it's like video chatting, right? If you or I were Skyping right now, I could see you, you could see me, that's real time. That's what telehealth is. Techno-health might be, I go through the portal and, for example, portal, the e-visits is techno-health. So a lot of the systems like eClinicalWorks, AthenaNet, I can tell you the ones I've worked with. I think most of them have it. eClinicalWorks, Allscripts, ECW, they have portals, right? Patient portals, where a patient can send a message to the office or to the provider. The patient sends the message, the provider gets the message. The provider can choose to either send a message back and communicate to the patient that way. This is now the provider work, right? Send a message back that way after doing some work in the office to figure out what they do with it, and send a message back to the patient, or the provider may pick up the phone and contact the patient. However the provider decides to communicate with that patient, that's a provider choice. They are doing what's called an online visit and that kind of stuff. They're using technology to communicate with the patient, right? So that's the code sets, the 99421 to 423. That's what we'll call e-visits. That's part of that techno-health we're talking about, because we're using technology. We're using our HIPAA compliant portals. Documentation tip on that, I would recommend you take that, and you have the capability, if it's done through your EMR, the query that comes from the patient, because it's patient initiated, that comes from the patient gets stored in the chart. So you can save that in the chart so it's evidence that the patient initiated that encounter. Now this is going to be tricky during this time, so you may actually send out a blast to all your patients to say, go to our website and, generate the encounters to schedule your appointments online. for your follow-ups if you need medications or whatever the issue might be, to get the generation from the patients, because these are kind of different times than how these codes are typically used. Again, these techno-health codes, these aren't even part of the 1135 waiver. These were had some coverage even before the whole coronavirus emergency. So that first set was the e-visits, the techno-health. They also have this virtual check-in. So if you are a provider that doesn't have a portal, the phone, that kind of quick phone check-in, virtual, you're using technology. Your technology now is a phone. We all have phones in your practice. That's G2012. Okay. These codes that we're talking about now, these techno-health codes, are only for patients who are established with you. Just like the 1135 waiver requirement. These are only for patients who have an established relationship with you. The extra curveball there with the techno-health codes is that the patient cannot have seen you in 7 days or will not see you within 7 days or your soonest available appointment. So the virtual check-in visit is G2012. As I research kind of payer policies with regard to this, I'm not seeing a lot of the CPT codes for the telephone E&Ms being accepted kind of a lot, but I'm seeing this G2012 code being accepted a little bit more. And they both are kind of telephone encounters. It's just this one is kind of capped out. G2012 is 5 to 10 minutes of medical discussion. Based on where you are, it's not a high reimbursement code. You're looking at about $15, give or take, based on the locality that you're in. So that's that virtual check-in via phone. All you need is a phone medical discussion. If it results in you seeing the patient at your soonest available appointment, or 7 days, then you don't get to report this code. It gets wrapped and bundled into that service. There are codes for telephone visits. I am not seeing a lot of coverage for that under the waiver. However, this is where knowing your payer mix and doing that payer level research is important. I have a client in the state of Illinois, Blue Cross and Blue Shield of Illinois. You can find this on their website. I think as of March 2nd, I think they put on their website. They are actually covering, once the 1135 waiver was granted, part of when they applied for the 1135 waiver, they indicated that they would cover the 99441 to 99443. Those are in your CPT book. Those are for the telephone E&M visits. So they're kind of like the equivalent of G2012, except G2012 is just one code and it's 5 to 10 minutes. 99441 to 443 changes. They're time-based for 5 to 10, 11 to 19, or 11 to 20 and 21 or more. So it increases based on a number of minutes, wherein G2012 is just a flat phone fee. I do see Blue Cross and Blue Shield Illinois saying they're adding payment for that. They've not published anything on a fee schedule or told you an amount, so you'll have to just kind of price it and hope if you are in the state of Illinois. However, I'm not seeing a lot of payers pick up 99441 to 443, the telephone E&M. So if you're a provider that feels it's too cumbersome to deal with the AV, you don't want to use Skype, you don't want to use Messenger, your EMR system can't do it, or it's cost prohibitive for you to implement it, you may be able to capture it with G2012. Again, the reimbursement isn't high. Depending on the state you're in, like I said, the state of Illinois, I had that, I'm sorry, I lost that. The state of Illinois, the reimbursement was like $15.72 for the state of Illinois $15.72 in the Medicare fee schedule for the G2012. So not a lot of money, but it allows you at least to continue care with your patients and check in to make sure they're fine during this time. So those are your codes. With your e-visits, make sure the patient initiated encounter through the portal is saved in your chart. When you are documenting providers, make sure you document what it is. So if it's via phone, make sure your encounter says it's a phone encounter, so we know it's a phone encounter, and that's what the code is for. If it's an e-visit, save the portal this portal message that they sent, save that to your chart. If it's telehealth, then say it's telehealth and save that image of when you're communicating with the patient. You can swipe left on your, swipe left? Yeah, swipe left on your phone, or right. I'm not sure, I'm not a technology person. You can swipe on your phone to store that image and make sure it gets into your chart. Also, just know CMS pertains to the government. So that's Medicare, that's Medicaid, that's the Children's Health Insurance Program, may affect TRICARE and things like that. But your commercial payers are a whole other animal. So you must do that research. Some of the payers are completely waiving cost shares for the patients with regard to telehealth, others are not. Some of them are saying the patients still have cost share responsibilities. They're covering, some are covered at 100%. Others are saying, providers, you can go ahead and write the patient's cost share off without penalty if you choose to. So know that so you can communicate that to your patient. Also remember consents. You're going to need to get consents for these services for the TeleMedicine services. Again, I want to specify these are not these are the physician-based services. These are not primary care physician-only services. One of my pain physicians are like, well, this is great for the internal medicine and primary care physician services, but I don't think it really fits for us. Not true, although probably primary and certain specialties would use these codes more than others. These codes are not limited to primary care physicians. These are for all as we socially distance and want to stop the spread of this virus. These are for all providers who are able to use it. And the OCR rule of allowing Facebook and Skype really kind of helped providers a lot that didn't have the capabilities within their system. Likely when you code your E&M, you're probably going to end up coding it based on the amount of history you take. And you'll have to actually take your own histories, the amount of history that you take, because if you're in your home, your MA or your nurse is not with you. Your history and your medical decision making, just because your exams are likely going to be a little more limited. You're only going to get what I call the visual exams. If a patient has a cuff, maybe something like that, but only what you can see. So you might be able to observe from a pain perspective a patient's gait, or if you're orthopedic, a patient's gait. Respiratory, you might be able to see whether their breathing is labored, but you won't be able to listen to their lungs and their heart. So anything that you can't see or kind of hear without touching might be limited. So when you're picking your level of E&M in your code, keep that in mind. It may not be as high, but when you look at the levels of 99212 to 99215, they still come out a little bit higher than some of the reimbursement associated with the TeleMedicine codes. So I hope you found this helpful. Again, there are many sources for education here. There are people that have been doing telemedicine long before I've delved into this about 2.5 or 3 weeks ago. One person, and I hope she doesn't mind me flagging her or tagging her, that I have a great deal of respect for is Terry Fletcher. I think in any video that you use, or resource that you use, I would not use it as a Bible unless it has, excuse me, careful coughing nowadays, people are frightened of that. Unless it has your payer mix level granularity, you're still going to have to do some work, and prepare to appeal claims or adjust your claims, because unless you do the payer research up front, you're going to likely, oh, well, POS2 didn't work, let me try the modifier 95. Oh, that didn't, you may have to bounce back and forth with it. So another thing I forgot to notice, part of the 1135 waiver, providers who are out of network may also be able to treat patients without a penalty. When it comes to like credentialing, the 1135 waiver allows a lot pre-certification and pre-authorization. Some of those requirements are also being waived under the 1135 waiver. So you're going to find a lot of benefits to this 1135 waiver, because again, the goal is to ensure that we're able to continue to provide care to the patient population and address the needs of the patient in time of emergency. So I hope you found this video very helpful. Please do your payer research so you can capture the reimbursement and continue the quality of care you need to for your patients. As always, if I can ever be of support, let me know. And thanks in advance to all the frontline providers who continue to operate and treat patients in lieu of this very, very scary time and virus. May God protect and cover us all, and be safe.